February is a short month, and it's already time for another Puscast, a review of the infectious disease literature covering the last half of the month of February in the year 2018. References and links to my growing multimedia empire of books, you've bought my books, haven't you? Apps, podcasts, etc. are at edgydoc.com. But enough of the self-promotion. Let's move on to the literature, shall we? As always, we start with viri and move our way up the evolutionary ladder, or perhaps escalator of complexity. How often do you find STDs in patients with primary HIV infection? A lot. This study did just that. They screened for STDs and found chlamydia in 50%, gonorrhea in 25%, and syphilis in 19% of people presenting and being discovered to have primary HIV infection. These were all asymptomatic STDs. Risks, not unsurprisingly, included anal intercourse and condomless sex. Unsafe sex, not unsurprisingly, leading to an increased risk for STDs. But patients who do have risky behaviors, especially men who have sex with men, should be screened frequently for asymptomatic STDs. In a study with similar results, they looked at the prevalence of anal HPV in men who have sex with men. It was predominantly an African American population. And in Houston, Texas, home of many an infectious disease study. Just today, I saw that Texas is one of the least happy states in the union. I wonder why. Seems to be one of the most infected states in the union. In a sample of young men who have sex with men, they found that 3/4 of their population had at least one high-risk HPV virus, and that 40% had HPV 16, and slightly over half were HIV positive. HPV, of course, being a risk for anal cancer, and I wonder if we have a vaccine for that. Oh, wait, we do. Given the lack of popularity of condoms, it would probably be a good population to be aggressive with HPV vaccination. I think the best population to vaccinate would be anybody who's ever going to be sexually active. But if you have to do targeted vaccination, men who have sex with men would be one you would really want to emphasize HPV vaccination in. Hopefully flu season will be winding down pretty soon. So what's new in flu in the last 2 weeks? Now, when I think of cruise ships, I think of norovirus, especially the famous shit ship that got stranded with everybody with bad diarrhea last year or so. But good news, norovirus is not the only infection spread in cruise ships. This study showed that there was an outbreak of H3N2 on cruise ships heading up to Alaska in 2015. The patients being hospitalized in Canada, so they got to experience some socialized medicine. And it was a grand total of 25 patients. So add influenza to your list of diseases that can be acquired during cruise ship travel. It looks like the flu vaccine this year isn't as bad as they said initially, with the CDC estimating that vaccine effectiveness this year was about 36%. Not great, but better than nothing for preventing the acquisition of influenza. How long does the flu vaccine work? This meta-analysis looked at how well flu vaccine protected over time and found that there was a decline for vaccine effectiveness. It was more predominant for the H3 and type B and less important for influenza H1s. So in the 180 days following vaccination, you're better protected against H1As than you are H3As and type B influenza. Again, this gets down to the fact that we really need a better influenza vaccine. And it makes answering the question, when should I get my flu shot, a little less clear. Like so much of medicine, I suppose there is no right/good answer. I always like to ramble on about the multiple beneficial effects of getting the flu vaccine beyond not getting the flu. including decreased risk of hospitalization, decreased risk of getting in the ICU, decreased risk of dying should you get flu. But here's a study that showed that patients who got the flu vaccine, quote, had a decreased risk of postoperative intensive care admission, shorter hospital days, lower medical expenditures, as well as a lower risk of postoperative pneumonia and in-hospital mortality. Even someone who is as gung-ho about vaccination as me can't believe that it's the flu vaccine that led to those beneficial downstream effects in this Taiwan population. So, unfortunately, I suspect this may be an epiphenomenon of who does and does not get the vaccine rather than the vaccine itself, as I can't come up with a plausible explanation for why this would occur. Association not being causation. Still, every little bit helps. Because similarly in Taiwan, those who got influenza vaccinated were less likely to get tuberculosis. The heck? I mean, there is this interesting literature in the pediatric population, which I just barely look at, that shows that kids who get vaccines not only get less vaccine-associated illnesses, but they get less infections in general. It's a peculiar literature. And regular listeners/readers of my multimedia empire know I hate this whole concept of boosting the immune system as a rule. But there is something to say for getting your immune system aggravated a little bit by vaccinations, over and above the protection you get from whatever is in a specific vaccine. As always, vaccination, especially influenza vaccination, is complicated. Or maybe I just don't want to live in Taiwan. And a couple case reports, as well as a review of the literature, pointing out that one of the complications of severe influenza can be invasive pulmonary aspergillosis. So that patient on a vent with severe influenza who now has aspergillus in their bronch or sputum don't necessarily blow it off. I mentioned before that the Borg had it wrong. Resistance is not futile. It is inevitable. And another study documenting our slide into the post-antibiotic era looked at multidrug resistant Mycoplasma genitalium. This is predominantly a population of men who have sex with men and who are HIV positive, and the amount of resistance was remarkable. About 10% of patients had urogenital or rectal disease, and macrolide resistance was found in about 70 to 80%, and quinolone resistance 30 to 40%. There was a lot more resistance in the rectal specimens than the urogenital specimens. I suppose a harsher environment leads to more resistance. Be that as it may, this is another organism, along with gonorrhea, that's becoming probably impossible to treat. There are some newer drugs coming down the pike, but a nickel says that they won't be effective for long. And there's something about STDs, with the exception of syphilis, that loves to become resistant to antibiotics. And speaking of gonorrhea, in Washington, specifically Seattle, they found that gonococcal isolates of Neisseria gonorrhea were resistant to azithromycin about 5% of the time. I'm still betting on gonorrhea to become the first pan-resistant routine pathogen of humans. Chronic acute fever needs to be treated for a year and a half at least, 18 months, with combination antibiotics. It's usually a tetracycline plus hydroxychloroquine. But what if patients can't tolerate that? Is there another option? This study compared patients who were treated with tetracyclines plus hydroxychloroquine versus those who got tetracycline plus a quinolone and found similar efficacies. So that if the patient could not tolerate the hydroxychloroquine, they could always go on tetracycline plus a quinolone instead. Unfortunately, it was an observational retrospective study. What are you going to do? But it would appear that you have at least two options for the treatment of chronic acute fever. Although 18 months of quinolone, that's going to give you some long-term side effects. And as long as we're on Q fever, there's a case report of a female in Israel who developed a breast implant infection with Q fever, presumptively living downwind from Coxiella-containing cattle. And at the time of surgery, 6 people were exposed as they removed the implant, and subsequently 3 of them developed seroconversion to Q fever. Although rare, if you're going to take out infected tissue and you know it's Q fever, be wary that you could have exposures to your staff, and post-exposure prophylaxis may be warranted given the high infectivity of Coxiella. There was an interesting study out of France where they used post-exposure prophylaxis of doxycycline in men who have sex with men who had high-risk behavior. There was no HIV seroconversion, but they had the patients take doxycycline after an exposure, and the rates of sexually transmitted diseases compared to placebo were at least 50% less with similar side effects. And of the patients with the new sexually transmitted diseases, a full 3/4 were asymptomatic, as we talked about earlier. I would fret that you're going to get short-term benefit, a decrease in STDs, with more long-term resistance. But what are you going to do? Damned if you do, damned if you don't. Corynebacterium can be fairly promiscuous with spreading their genes. As a rule, diphtheria toxin is made in Corynebacterium diphtheriae. But there were 2 cases in Japan of Corynebacterium ulcerans, a zoonosis, that had severe pneumonia that had pseudomembrane formation, and it turned out their C. ulcerans was producing a diphtheria toxin. Cats seem to be the usual animal that people get it from, as well as cases in cattle. Although I have yet to see anybody have a companion cow walking around the city. I'd like to see them try and get one of those on an airplane. It would be fun to ask the companion animal to move over. Oh, that joke was an utter failure. It's always important to remember that ecologic niches need to be filled. Since the introduction of the 13-valent vaccine, Israel has seen an increase in serotype 12F of Streptococcus pneumoniae, not one covered by the vaccine. Now it's the most common isolate in Israel for invasive pneumococcal disease, and yay, it's penicillin resistant. No good deed goes unpunished. And unfortunately, what we really need is an 82-valent pneumococcal vaccine. It'd probably come in the size of a turkey baster. God, that would be big. I've been told in my institution a procalcitonin runs about $120. This study got 4 procalcitonins on patients, baseline 24 hours, day 3 and day 5, to follow the procalcitonin levels in patients with cellulitis. They went up and then they went down. And they suggest using the procalcitonin in cellulitis as, quote, an adjunct to clinical decision-making that could reduce unnecessarily broad-spectrum and prolonged antibiotic regimens and warrants further study. Jesus Christ, if you can't take care of cellulitis without a procalcitonin, you're in some serious hurt. You have to look at the leg. How hard is it? Follow the fever curve. Ask the patient how they're doing. Since it's usually strep of one sort or another, they all need just a little cefazolin elevation and someone looking at the leg. This so strikes me as killing a fly with a sledgehammer. I mean, it's a nice little study, but seriously, anybody who uses a C-reactive protein to follow something like uncomplicated cellulitis is way overdoing it. No wonder healthcare costs so much in this country. Jesus. Of course, this is a guy who hasn't ordered a C-reactive protein probably in his entire career. So, what do I know? We've talked, by we mean I, about the equivalency of cefazolin, or as my pharmacists pronounce it, cefazolin, and nafcillin in the treatment of staph infections. This meta-analysis specifically looks at side effects of those two and found cefazolin to be markedly safer compared to nafcillin in terms of hypersensitivity reactions like nephritis and hepatitis. And patients were more likely to continue their cefazolin and not have to discontinue it because of adverse reactions. I have pretty much gone over to the dark side and give cefazolin to virtually all my serious staph infections. Although I do fret because some staphylococcal beta-lactamases have more activity against cefazolin than nafcillin, but we can't tell if our staff have those particular beta-lactamases. So there's always a bit of fret in really serious infections. But most of the time in most patients, cefazolin, equal efficacy to nafcillin, a lot cheaper, a lot less side effects. I can't speak for cefazolin though. It seems like every day, especially with the multitoph, people call me about bugs I've never heard of. So here's two that I've never heard of and that I will probably forget unless I get called by the lab because of the multitoph. The first is a mold. It's called Nanniziopius, Nanniziopisis. These things really need to come with pronunciation guides. A mold that evidently causes fatal infections in reptiles. I suppose our senators will be at risk. There are a smattering of cases in human beings, predominantly immunocompetent patients like HIV, who do not do well. It is beta-D-glucan positive, but galactomannan negative. So a new mold to think about, an occasional patient, Nanniziopisis. Both patients, by the way, were in France and both had recently been in Africa. The other weird bug that I'll probably mispronounce is Delftia surhatensis, Delftia space Tsurhatensis. Yes, again, we need pronunciation guides. A hodgepodge of infections reported out of France. They were mostly identified on the multitoph. This organism is evidently found in sludge, at least in Japan. I don't know the French word for sludge, and is susceptible to third-generation cephalosporins and carbapenems. So there's a mold and a bacteria for you, neither of which I can pronounce, both of which need pronunciation guides. The new C. diff guidelines came out this month. The big thing is start with vancomycin. But there have been a couple other articles since the guidelines came out that haven't been included. One out of CID suggests that earlier stool transplant improves survival in patients with C. difficile. The other is how best to dose an antibiotic. This study compared extended pulse fidaxomicin to vancomycin and actually found that fidaxomicin was better. The way they dosed it was 200 milligrams BID for the first 5 days, then once daily on alternate days for day 7 through 25. And they say they had the lowest recurrence rate ever published. A Trumpian result. Believe me, it was the best. But I have to admit, I'm somewhat drawn to this concept of a prolonged pulsed fidaxomicin, as by keeping the C. diff beat down over an extended period of time, at least theoretically, you allow the normal bacterial flora to grow back. I think it sounds like a great way to give fidaxomicin on that principle. If you're planning a trip to Italy this year, remember they're having a recurrence of a specific Salmonella enteritica strain, Serovar napoli. Evidently, it first got into Italy in 1982, where it was associated with contaminated chocolate, and it had been imported back then to cause 2 outbreaks. It kind of disappeared, but now it's back and causing 6% of the Salmonella cases in Italy, and they don't know where it's coming from. I think there was an outbreak at Vestuvio's in New Jersey. Deep fry everything you eat. I can't enforce that concept enough. And if you think, oh, I don't want to go to Italy, I'm going to go to Pakistan instead, well, they got a multi-drug resistant Salmonella typhi there. So choose your Salmonella. Personally, I'd rather get Salmonella eating food in Italy over eating food in Pakistan. But that's just me. You watch these vegetations flop about on an echocardiogram and they always make you nervous. Why don't they cut loose and fly downstream? A meta-analysis this month demonstrated that the bigger the veg, the bigger the risk of embolic events and death. The 10 millimeters was the upper limit of safety, as it were, for vegetations. Vegetation size has never been an absolute indication for valve surgery, although I've always wondered about valve replacement, as the best treatment for endocarditis. The New England Journal article showed that people who had their valve replaced early tended to have fewer embolic events as a consequence. It's too bad you just can't debride them. I've asked my radiologist to do percutaneous drainage of vegetations on heart valves, and for some reason they're hesitant to do it. What a bunch of big babies. But that 10 millimeter and above should give you pause in a patient with endocarditis. And how long to treat enterococcal endocarditis? This retrospective study looked at patients who had AMP plus ceftriaxone versus the more old school AMP plus gentamicin. It said you can treat enterococcal endocarditis with 4 weeks if it's uncomplicated. However, those were the patients that had relapses, especially if they were cirrhotics. And of course, the last thing you want to give a cirrhotic is gentamicin. But be that as it may, it would look like a 4-week course of antibiotics is not suitable for enterococcal endocarditis. And I must confess, I've never seen a case of uncomplicated enterococcal endocarditis. They've always gotten 6 weeks with me. And duration of antibiotics. Traditionally, when you have a neutropenic febrile, you keep them on the broad-spectrum antibiotics until their neutrophil count recovers. This study randomized patients to the standard therapy versus stopping antibiotics if they've been afebrile for 72 hours, regardless of whether or not they remain neutropenic. And the patients did just fine, thank you very much. In point of fact, they did better. They had fewer side effects / adverse reactions, and they had less exposure to antibiotics, presumably breeding less resistance. So the duration of antibiotics for neutropenic fevers is 72 hours that they've been afebrile. They also note that they did not use prophylactic antibiotics with the exception of TMP sulfa. I've always been quite the pessimist about treating atypical mycobacterium in the lung, especially MAI, which I think most of the time you just give patients toxicities and expense without much efficacy. This study looked at surgical interventions for patients with Mycobacterium avium and Mycobacterium intercellulare, and the patients did pretty good. Of the patients, only 4 recurred and 1 developed a new infection, and 77% were cured of their disease, which is pretty good. The downside is there was 1 case of hospital mortality. That's the bummer part. But I'm still inclined to think non-tuberculous mycobacterial infections of the lung, especially MAI, I think surgical resection, if you can do it, may be the way to go. So you have an AIDS patient with Cryptococcus antigen positivity in the blood. Do they have meningitis? The answer is yeah. About a third will have asymptomatic cryptococcal meningitis. So basically, any AIDS patients with a positive cryptococcal antigen in the blood should be evaluated for meningitis. And if for some reason you can't do a spinal tap, given those odds, you should probably treat them for cryptococcal meningitis. There's a report in Emerging Infectious Diseases, a review of all the coccidioidomycosis outbreaks in the world between 1940 and 2015. Most of them were not unsurprising. Archaeological digs, laboratory outbreaks, construction outbreaks. The 2 that I thought were most interesting, one was Native American site disruption, of which there were 2 outbreaks, and then armadillo hunting in northern Brazil. Who knew that armadillo hunting was a thing in Brazil and that you could get coccidioidomycosis doing it? All the other outbreaks were associated with kicking up dust, which you'd expect. I guess going after armadillos does the same. And to think the only thing I worried about with armadillos was leprosy. More problems for the Navy. There was a recent article that suggested there are at least 27 different viruses that are present in human semen. How about parasites? This suggests that you can find Entamoeba histolytica, Schistosoma hematobium, Trichomonas vaginalis, Trypanosoma cruzi, and Toxoplasma gondii in semen, and therefore a potential vector for the spread of the disease. Condoms, condoms, condoms. Almost as important as frying your food. I've often wondered if we make a mistake by not checking more antibiotic levels in our patients, though it's not easy to do outside of vancomycin and aminoglycosides. Certainly with the antifungals, it's important for both toxicity and efficacy reasons to check your azole levels. How about beta-lactams? Well, this study looked at trough levels of beta-lactams in patients, elderly patients, and found great variation, often being 0 for IV beta-lactams, cefotaxime, meropenem, and piperacillin tazobactam. And only 36% of patients had levels at an appropriate level for killing the organisms at hand, although they did not specifically look at outcomes in this study. So that's worrisome, and given the vagaries of human metabolism, etc., really it would be nice if we could always check our blood levels of antibiotics so we knew we were hitting our mark. That is something for probably the next generation of doctors to do. And that brings us to an end. I will mention that there are new guidelines out for the treatment of neurocysticercosis over at the Infectious Disease Society of America. You can peruse those at your leisure. They're especially handy if you've run out of Ambien. Otherwise, references are available at edgydoc.com, the home of my stagnant multimedia empire. Don't forget, if you like to learn infectious diseases, I have books, I have apps, I have other podcasts. I am the Medscape ID blogger, and every day, at least 5-6 days a week, on Twitter, I give you an ID factoid. A little bit of information from the medical literature to tickle your brain. Because you know my motto, the world needs more Mark Crislip. Otherwise, I'll go watch the Blazers beat Minnesota, and thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. Shall follow along with you. Thank you. In dictation. Goodbye.